Welcome, everyone. Thanks so much for being here. My name is Kate Venturini. I am coming at you live from the great state of Rhode Island. And I am here representing the University of Rhode Island Cooperative Extension. We are co-hosts of this really exciting lecture series that we put on each year called the Plugged into Energy Research Lecture Series. And this year, the lecture series is sponsored by the Rhode Island Energy Efficiency and Resource Management Council. And we'll hear a little bit more about the EERMC later on this evening after we hear from our presenters. But tonight's webinar or lecture is titled Energy Efficiency, Human Health, and COVID-19. Pretty straightforward. And today is Wednesday, October 7th, 2020. So a few housekeeping items before I introduce our first speaker. One is that I would encourage everyone to find their way to the Q&A button. If you're on a phone, you may have to do some swiping. If you are on a laptop or PC or Mac, there is a white box with almost a full question mark in it. You click on that. When you have questions for the speakers, feel free to enter your questions in that Q&A box. And the plan is to pause after each speaker's presentation, do questions for them. And if we have time at the end and there are still questions that have not been answered, we will do our best to answer them. So the Q&A, also, in case anyone is wondering or asking you if they're not able to be here right now, this presentation is being recorded and it will be uploaded to the URI Cooperative Extension YouTube channel. All of you who are here and who registered will receive a link to that. And you'll also receive a link to a survey that we would really appreciate you filling out. We do read all of the responses and we use the information you share with us to make these programs better and better every year. And so I hope you all enjoy this one. And I'm going to give our first presenter presentation rights while I introduce her. So Emma Pollack is a research analyst for the Health and Environment Program at the American Council for an Energy Efficient Economy, also known fondly as ACEEE. Emma conducts research and analysis at the intersection of energy efficiency, human health, and the environment. She's well positioned to speak here tonight. And prior to joining ACEEE this year, Emma worked at the Stone Barn Center for Food and Agriculture as a program associate and educator. Conducted research on infectious diseases at the Institut Pasteur in Laos, and most recently interned with the Planetary Health Alliance. Emma completed her master's degree in public health from Harvard University and earned her Bachelor of Arts in History from Cornell. I'm very excited to make Emma's acquaintance, and we appreciate you being here, Emma. Take it away.
Thank you. Thank you so much for having me here tonight. I am very excited to be talking about sort of the opportunities at the health and energy nexus. So firstly, ACEEE is a research nonprofit founded in 1980. We act as a catalyst to advance energy efficiency policies, programs, and behaviors. And I specifically, as mentioned, work on the health and environment team. So I wanted to begin tonight, as most things begins these days, by framing the conversation in the context of COVID. As many of you know, COVID has disproportionately impacted communities of color. As of September 15th, as this chart shows, when adjusted for age, Black, Latinx, Indigenous Americans were dying at a rate more than 3 times that of white Americans. One source stated this in a really poignant way by saying, if they had died of COVID-19 at the same actual rate as white Americans, about 21,000 Black, 11,000 Latino, 700 Indigenous, and 80 Pacific Islander Americans would still be alive. So there's a long list of factors that contribute to these disproportionalities, from greater workplace exposures to the inability to work from home, to the dependence on public transportation, housing conditions, and access to quality care, testing, and PPE. The point really is that the racial disparities of COVID-19 are the result of systemic racism. And this becomes increasingly clear when we think about environmental justice. Environmental justice communities are further disproportionately burdened by COVID. They face long-term air exposure to air pollution and are simultaneously more likely to face energy insecurity, economic instability, and chronic diseases. And so recently, we've seen more studies look at the linkages between air pollution and COVID mortality. One study out of Harvard showed that long-term exposure to PM 2.5 was associated with an 8% increase in COVID mortality rate. A more recent study came out last month from Emory that looked at nitrogen dioxide and showed that there's an associated 16.2% increase in COVID mortality. So the pandemic really highlights, it puts a spotlight on environmental justice, and it also highlights the importance of a healthy home. As we're all asked to shelter in place, we want to make sure that that place is a space that is a safe space, a space that is free of toxins, allergens, pollutions. And all of this has a direct connection to energy here. By consuming less energy through energy efficiency programs, by switching over to renewables, we can reduce our overall consumption and reduce our reliance on fossil fuels. This in turn can clean our air and help to reduce the health disparities. With housing, which we will get into across the evening, there is a clear link between weatherization and a healthier home. And so I don't want to get too far ahead of myself with that, but I really wanted to open tonight with COVID because it provides an example of how we can re-examine our perspective of health in the efficiency framework as well as in all other work. It has illustrated that the underlying conditions that impact health, and it also has brought about many important and previously overlooked issues to the table. It has also made people more aware of the social determinants of health and really highlighted the need to rectify many of these underlying conditions. So switching back to the topic that brought many of you here tonight, what does this mean in the context of energy efficiency? As other presentations will discuss in greater detail, energy efficiency can play an important role in improving the health of building occupants. But I also wanted to note that energy impacts health across all levels. I don't want to spend too much time here, but I just want to say that we're not just talking about the individual. We are looking at the built environment, the community level, the societal level, the economic and environmental impacts. So for example, on the individual level, one may say, will I have an asthma attack today? When we think about it in the built environment, will my home trigger an asthma attack? On the environmental impact level, will the air impact that asthma attack? So these are really all key aspects that can be used to make a case for the use of health funding and really draw the linkages between weatherization and health. I think my slides moved around a bit. There we go. That's where I was hoping to go first. So to go back a slide, so how is energy efficiency related to building occupants' health? And I know we will talk more about this in other presentations, but I just wanted to highlight that poorly sealed building envelopes allow pests, moisture, and air pollution to infiltrate. All of these can harm respiratory health through mold growth and the introduction of allergens and disease. Leaky windows and poor insulation can be it can cause extreme temperatures in the home, and improper ventilation and incomplete combustion from inefficient appliances can also degrade air quality. So energy efficiency upgrades can kind of come in and intervene with a lot of these and help make a home safer and healthier by improving housing conditions, by reducing temperature swings, limiting exposure to air pollution. And this can help reduce the number of asthma attacks, COPD, headaches, fatigue, lung cancer, the list goes on and on. And when we also look at the intervention of weatherization, we're not just looking at the decrease in hospital visits and the direct impact on health, but we can also look a little bit more holistically and see improved quality of life, fewer days of missed work, fewer days of missed school, improved comfort and safety, and reduce financial burdens. So to jump this slide and get into the next slide, this all kind of goes around this idea of what is health, what determines health. And so for many people, health is the relationship between a patient and a doctor. It's the access to care, it's the quality of care. But increasingly, the healthcare sector and populations as a whole are really looking at health in a much more holistic way. They are looking at what is happening at the many different scales that might contribute to health outcomes. So as this slide shows, 20% of health is really determined by the care that they receive. Another 30% is the health behaviors. Is this person a smoker? Do they exercise? What do they eat? And the other 50% is really what I want to focus on tonight, and that is what we describe as the social determinant of health. These are conditions and environments surrounding people that affect health and well-being, and may include social, economic, environmental, physical, societal factors that impact an individual's health. And we see a lot of overlap between energy efficiency and the social determinants of health. And so I just want to highlight some of the ways that programs that promote efficiency might improve health outcomes. So this here shows what has been generally agreed upon as the 6 categories of the social determinants of health and the underlying each specific within each category. So the 6 categories we have are food, neighborhood and physical environment, education, community and social context, economic stability, and healthcare system. So when we start beginning to look into these categories, we can see the overlap of energy efficiency. So for example, by reducing the energy burden of a family and also reducing medical expenses, weatherization programs may improve the economic stability for a family, allowing them to access healthier food or medicine, or prevent them to make that decision between can I afford medicine, can I afford food because my energy bill is so high. Similarly, by reducing the number of days missed from school, children living in a weatherized home might see improvements in their education, which could eventually improve their overall well-being as a child, but much more so as an adult. So there are many connections that can be drawn, and it is important for programs to really think critically about what impact they currently have, how they can have a further impact, and how can these impacts and how can they measure these impacts to really leverage funding from a diverse array of sources. So it's a really valuable exercise to look at these programs and see where your program, from all sectors, can really engage to improve these social determinants of health, and also where they overlap. Many times energy programs are thinking about the direct energy impacts and not necessarily the non-energy benefits. So by looking at these determinants of health, you might see that you are already accomplishing X, Y, or Z, or maybe you can partner with somebody to do so. And this may really help to expand programs to have a deeper impact. And I also wanted to stress the idea that if an energy efficiency program is already going into a home, there are the obvious measures that they might be including. Air sealing, insulation, windows, high efficiency appliances. But they're also already in a home, and you might think about what health and safety measures can they be addressing in tandem with the energy measures. So when we look at the potential overlap in energy efficiency and health services, there's a tremendous potential for collaboration. And programs that are designed to address health can really maximize their impact by incorporating some elements that aren't strictly efficiency, such as handrails, smoke detectors, pest remediation. So what this diagram shows here is that it shows how these services overlap. So the green circle details specific energy efficiency measures, those traditional ones that I just mentioned: ventilation, circulation, envelope sealing. The blue circle shows asthma mitigation measures, so pest control, patient education. The yellow circle shows thermal injury prevention, and the red shows interventions for trip and fall. So as you can see, there's a lot of overlap, and this is a really important concept for people to think about when developing organizations, and really also when seeking out funds, which brings me to the second sort of part of this talk, which is what funding is available and how do we pay for this. So there are a huge number of potential sources for funding across sectors. And this diagram here shows some of the cross-sector funding sources that my team has found. So you have the traditional weatherization funding programs such as LIHEAP and WAP. You have the healthcare funding, which is what I'll be talking about in a minute. And then you also have some other sources such as government programs on local, federal, and state levels. You have climate and resilience funding, private funds, programs through HUD and EPA. But tonight we're really going to focus on the healthcare sector. And this is partially because my colleagues Sarah Hayes and Christine Garbodi recently released a research paper that that really focused on 6 different federal funds that they examined as sources that could be used for preventive services, and really how do you grade those energy and health sources. And this ties into a few different reasons. One is currently the health spending is in the trillions of dollars per year. And there's this growing movement across parties towards addressing preventive health services. So we are seeing a further investment in preventive services, and we are seeing a growing momentum towards those social determinants of health. So they highlighted these programs here. There is Medicaid, the Children's Health Insurance Program, the Preventive Health and Health Services Block Grant, a new program called the Social Impacts Partnership to Pay for Results Act Grant, National Asthma Control Grant, and the Lead Hazards Grant. I wanted to focus mainly on the 2 first sources, Medicaid and CHIP. And I just wanted to note that this list here isn't comprehensive. It just really represents a snapshot of what's out there now, what looks promising. And I also would say that it's worth noting that these 6 opportunities alone represent over $1 billion of funding or technical support. So there's a large source, untapped source, to say the least. So within Medicaid, there are 2 different mechanisms that we have been seeing towards paying for preventive services. And this is all sort of part of a general trend where Medicaid is looking at transitioning from a fee-for-service model to a pay-for-performance model. This allows states to provide more comprehensive services at a lower rate. And again, this goes towards the trend of targeting preventive health and social determinants. So the first mechanism here is through negotiation with managed care organizations, MCOs. So states have the authority to include non-traditional health interventions, such as weatherization, into Medicaid coverage, and they can negotiate with service providers to include these programs. We've seen a few different programs that have included negotiations with MCOs to target healthy housing programs. One notable one is in Washington, D.C., the Impact D.C. clinic. They have negotiated with MCOs to play a key role in connecting asthma patients to in-home assessors and service providers, and focusing on education as well as asthma mitigation in the home. The second mechanism outlined here is through amending state plans, and this can either be done through a state plan amendment or a section 1115 waiver, 1115 waiver, which is used to fund pilot programs. The state plan amendment is more permanent. The 1115 waiver is a 5-year program, but has renewal. It's often renewed. These both require legislative input, and so it takes a little bit more time. But we've seen these programs be used effectively. There's one exciting program that's coming out of New York right now, where they are on pause due to COVID, but recently NYSERDA and the New York Department of Health have partnered to launch a new pilot program where Medicaid is covering 100% of the costs for 500 low-income homes and providing full weatherization programs, really targeting asthma as well as energy efficiency improvements. So those two are Medicaid options. And then another really exciting opportunity we are seeing is out of the Children's Health Insurance Program. So CHIP serves children that are not usually covered by Medicaid, and states are allowed to spend a certain percentage of their CHIP funds on administrative reasons. A lot of times that administrative, they have not reached that cap. So they are allowed to use the remainder towards a program called the Health Services Initiative. And this is still matched with federal dollars. So there's a lot of flexibility in this. And we've recently seen a few HSIs be used for in-home health and safety, a few programs looking at lead remediation, and recently Maryland has started a program that supports in-home environmental hazard assessment and with a focus on asthma work. So for the sake of time, I will quickly mention the other opportunities that are out there. The Preventive Health and Health Services Block Grant can be used to fill unmet needs related to public health. The lead hazard grants are what they sound like, but oftentimes need supplementary funds. The SIPR program has been delayed due to the CARES Act. The National Asthma Control Program has been quite successful in targeting a lot of asthma mitigation and supporting in-state coalitions. So strategies for getting started with all of this. I just want to mention again, this isn't a comprehensive list, and there are a lot of different opportunities out there. So it's just some ideas of where to start looking and how to start thinking about what your program might need to do to begin braiding in new services and how the energy and health sectors can overlap. Again, keep in mind that health isn't just physical symptoms. Efficiency has the potential to improve financial well-being and impact residents through other means. So really be broad when you're thinking about sources of funding. Constantly keep your eyes out for new opportunities, especially now. There's been a huge change in discourse on the conversation around health and homes, which provides an increased interest in holistic public health work and potentially to be optimistic, a wave of impact. And a really good place to start is to look at the community you serve and think about what the local health needs are and get as much feedback and early involvement from community members as possible. So with that, I just wanted to leave you with a link to our new report, as well as 2 other reports that were released by the team recently. So the Braiding Funding Report talks about, as mentioned earlier, the various sources of funding. The Making Health Count really highlights how do you make a case to reduce healthcare costs, and how do you document those outcomes, and how do you monetize the outcomes. And the Protecting the Health of Vulnerable Populations highlights a variety of methods for measuring impact. And I think that is time. I thank you again for having me this evening, and look forward to hearing some questions.
Awesome. Thank you so much, Emma. Optimism is everything.
Optimism is everything.
So we're waiting for some questions to pour into that Q&A box. I would just start. We have just a couple minutes. I very much appreciate you sharing those resources, and I would just let folks know that if you weren't able to jot those down, we'll send them in a follow-up email, um, especially because that report by Sarah and company is quite new. Emma, are you aware of a place or an organization that is really doing a great job at building these types of partnerships and getting funding
Um,
that folks could look at?
yeah, the one of the most exciting ones is the one coming out of New York, because it's part of this whole Medicaid transformation model. So it was a multi-year model that sort of moved from that fee for service, to pay performance and sort of focus on value-based. And it's bringing together a wide variety of both government partners as well as community organizations. They've done an effective job of engaging environmental justice organizations. It'll be really interesting to see the results of that study, that program. I'm also very biased as a New Yorker, so that's the one that I like to talk about. Also, what's interesting, there's a new grant that was just released by HUD that is looking at how weatherization programs and lead programs can collaborate and measure health impacts. So it's a program, a grant opportunity that's focused completely on collaboration and cross-sector involvement. And we'll have a fair amount of details on measurement and how, if that is an effective means. So that's, I believe that grant, the applications are due by the end of November. So if people are interested in that, it's an exciting opportunity, but also it'll be really interesting to see the results.
Great. We had Chris Cole from NYSERDA speak at an event a couple weeks ago, and he talked about that wonderful program. We do have one question that you could answer really quickly. Where do landlords fit in all of this?
That's a really interesting question. I wish I could answer it quickly. Historically, a lot of the work has been focused on homeowners. Moving forward, I think there's a lot more engagement with renters, and I think there is a need for a further discourse on that. And I think it depends on the landlord. It's a really hard answer for that one.
We're going to, David, thank you for that question. We're going to continue that conversation on November 18th at our third lecture in this series. So mark that down on your calendars. No better place to be. And Emma, thank you very much. We may have a question for you towards the end, but for now, I'm going to switch presentation to Bruce, and I'm going to welcome dynamic duo of speakers up next, coming to us from Knoxville, Tennessee. So firstly, Bruce Tonn. Dr. Bruce Tonn is the president of ThreeCubed in Knoxville, Tennessee. His research and interests center on the evaluation of low-income energy and other programs that promote equitable, sustainable futures. Also, the convergence of science and technology on sustainable designs for community-based energy, industrial, and other systems. And also, he's very interested in the very long-term perspectives of sustainability with explicit concern for the well-being of future generations. Dr. Tonn received his Bachelor of Science in Civil Engineering from Stanford, a master's in City and Regional Planning from Harvard University, and a PhD in Urban and Regional Planning from Northwestern University. He is joined by his co-founder, colleague, and the Vice President of Social Equity at ThreeCubed, Erin Rose. Erin holds a Master of Science in Social Work from the University of Tennessee, Knoxville, and had a concentration in macro-scaled social work in the areas of environmental policy and justice, community organizing, and administration. Erin also earned her Master of Laws in International Human Rights from the University of Edinburgh, where my colleague Kaylin also went. Her current work involves the design and implementation of studies targeting energy program impacts on households of low socioeconomic status. We are very lucky to have Bruce and Erin here. And without further ado, the floor is yours.
All right, thank you so much. All right, let's get going. So we're going to present some data after nice broad overview presentation. And so we have data from our multifamily study that we've done in the Northeast and Midwest. We have data from a study that we're doing in the Tennessee Valley. And then as part of the Tennessee Valley work, we have gone back out in the field with our resident survey, asking about health questions, but also we've added a battery of COVID questions. So the multifamily study is funded by the JPB Foundation out of New York City and the Massachusetts Program Administrators. The goal was to assess the health and resilience benefits of weatherizing affordable multifamily buildings. So those are defined as buildings with 5 or more units. Our study partners were NMR, Slipstream, and the Center for Applied Research and Evaluation here at UT. We recruited buildings, a convenience sample basically. There was no one list of multifamily buildings in the United States, so it was kind of difficult to do. And so we went out and worked with utility companies and WAP programs and state programs and so on to identify buildings. And we recruited over 400 buildings for the study. And you'll see that we recruited almost 2,000 participants, or households to participate. And we surveyed the residents 2 times. Once just before the treatment group was weatherized, and then one time 1 year afterwards. The first surveys were done. We hang survey materials off of people's doorknobs in all the buildings we visited. We left over 7,000 survey booklets around the country. And the second survey was done by phone and mail. Here's our characteristics of our survey respondents. The main age, in the upper 50s, lower 60s. Most of the respondents were females. You can see that the household size is pretty small, which is one could expect for in the multifamily sector. So around 1.5 people, for example. In our national WAP evaluation, the average household size was 2.5. You can see that we have a diverse sample of as far as race is concerned. And a very large portion of our respondents are retiring. So that's a pretty characteristic of our multifamily sample. So we asked a battery of health questions, and these are just some selected health and social determinants of health results. One is we found that about half of our respondents reported having arthritis, which was a surprise, pretty high rate. And we found that, especially with respect to the treatment group, arthritis symptoms decreased post-weatherization, as did needs for urgent care and emergency department visits and also hospital stays. When we looked at the control group and looked at the differences, we still see that there was a decrease in medical interventions related to arthritis post-weatherization. With respect to social determinants of health, we found that there's a reduction in missed days of work post-weatherization. People have fewer bad days of mental health, fewer bad days of rest and sleep, fewer bad headaches, and trips, as was mentioned, trips and falls also reduced as well. We asked questions about thermal stress. We find that people are less cold in their units after weatherization. You can see there's fewer emergency department visits and doctor's office visits. The results with respect to being too hot weren't quite as robust as with respect to being too cold. But generally we find that there's fewer medical interventions needed post-weatherization. We ask a fair number of budget questions, so also related to disconnects. So We do find that in different samples, looking at single family versus multifamily, there are different patterns related to disconnects and shutoffs and how hard it is to pay for energy bills and so on. And you'll see when we talk about our Tennessee results that the impacts of weatherization on budgets are much stronger than we find in the multifamily sector, which is kind of interesting. All right, so weatherization across the Tennessee Valley, I'm going to report on 2 projects. The first project was called the Knoxville Extreme Energy Makeover Project. The Tennessee Valley Authority provided money to Knoxville, Tennessee to weatherize a whole bunch of homes. The goal was to reduce energy use by 25% in these homes. And because it was a TVA project, they only focused on the electricity. So there were only electricity heated homes in this study, which is okay for Knoxville. About 2/3 of the homes actually heat with electricity. You can see TVA has a big impact in the valley. And the Robert Wood Johnson Foundation provided us a grant to do this health study. The second project is called Home Uplift. So after TVA funded these extreme energy makeover projects, they funded Home Uplift, and a lot of money going into weatherizing homes in the 4 major cities in Tennessee: Memphis, Nashville, Knoxville, and Chattanooga. Matching funds were provided by the local power companies, such as our Knoxville Utilities Board, and TVA was kind enough to provide us a contract to do this health benefit study. And because I had the opportunity to combine databases, the next few slides I'm going to talk about will present data that we collected both for both KEEM and Home Uplift. You can see that pretty much the same gender distribution as a multifamily, but lower age, higher household size, fewer retired people in our sample. You can see that the health impacts are greater in this population and with this particular program in the single family sector. So you can see bad health days decreased a significant amount, bad mental health days decreased, bad days of rest and sleep decreased, headaches decreased as well. So a lot of good and strong health impacts related to these 2 programs. Looking at the budget impacts, you can see a big decrease in how hard it is to pay energy bills, though you can see that still post-weatherization, half of the respondents still reported it being difficult to pay their energy bills. Fewer trade-offs for not buying food to pay utility bills and vice versa. Fewer use of short-term loans like pawn shop loans. And the households are better able to afford their prescriptions and avoid disconnections. So let me turn this over to Erin, and she's going to talk about our post-COVID, when we got back into the field after COVID and what kind of results we got.
Right, thanks Bruce, and hi everyone, good evening. So 2 important points here. One, we really didn't have a choice but to actually stop our survey in the field when COVID really took hold of Tennessee. Our survey house operates through the University of Tennessee, Knoxville. And so when the university shut down, our survey house went away as well. So, but actually it was a good thing just in terms of us really thinking about how we could use the survey to, now we would have to, control for households that had COVID-19, especially for certain health outcomes like asthma and COPD. We wanted to know who in the household had COVID-19. And then we also wanted to see how something like weatherization might, like Emma was suggesting, provide a safer space while people are sheltering inside. So how might weatherization improve those outcomes for people with COVID-19 or even those who are isolating, spending more time indoors? So we really modified the schedule, the survey halfway through, which is not something you do as in social science research. It's like the opposite of what you want to do for consistency. But we really didn't have a choice. And then we just thought we would just go with it, and it became an opportunity, even though it really kind of slashed our sample size in half for our year 2 survey. So at some point we wanted to at some point we'll try to figure out how we might regain that sample power in order to detect any statistically significant changes from the pre-weatherization environment to the post-weatherization environment. But we're in process still, and we still have time to make that decision. But what we wanted to do first, and I think Bruce kind of skipped over this part, which I think is an important thing. What TVA did differently, I think, than a lot of other weatherization programs, after they moved away from the Keams pilot and went into home uplift across the Tennessee Valley, they were really intentional about recruiting Black homeowners. So you have 75% of the sample identifies as Black or African American. And that's significant when you're really starting to think about racial disparities and also COVID-19 and the underlying health issues that make your response to COVID-19 more severe. So thinking about this sample right here, what happened during COVID-19 in terms of employment status? You see with a younger control group, you have more employed household members or respondents who were employed. And what was surprising to us too is, and this is something TVA wanted to know, was who was being served by their program. And I think that the amount of essential workers in this sample is also kind of interesting to us in terms of the benefits. And it also helps us think about in terms of energy security and disconnects, and who has, if you have these essential workers out there who are, and not just, obviously nobody should be disconnected, but it also tells us who is benefiting from these types of programs, and important to TVA, and it should be important for all weatherization providers. So I'm going to go, actually, Bruce, can you go to the next slide? I don't think I have control. All right, so this is great, and it's really what we wanted to see in terms of the energy affordability and habitability of the home environment post-weatherization. So in the middle column in the treatment section, you can see what happened post-weatherization, and it's pretty much in line with what Bruce had found in the merged study slides, and you see everything really going in the right direction post-weatherization. And this is where we'll start to see how did households fare during the time of COVID-19, and how did that what we started to see in terms of the improvements in these indicators for energy affordability. How did that change, or did they change at all during COVID-19, and in which ways? And was it different than the control group? And we do see that we have these improvements generally on balance in the treatment group, and then in the control group, you might see some slight improvements, but you also see some indicators with worsening conditions or outcomes. So again, we'll try to sort out how to manage those two post or year 2 samples, and whether or not they can or should be combined, if it's appropriate to combine them to regain that statistical power, and or how to control for that factor for COVID-19 in our study. But I think this is an important think about the health outcomes, especially keeping homes at unhealthy temperatures. You see a pretty significant reduction, and I'm just saying significant loosely here because we're still in process and we haven't actually run those types of tests quite yet. This is kind of hot off the press just for you guys. But when you see, 22% of people saying that they had their home at an unhealthy temperature in the past 12 months, and that dropped down to 6%. Post-weatherization, I think that's a pretty great indicator for these programs. Bruce, will you go to the next slide? I'm going to look at my time here too. Unfortunately, we didn't see, at least with this sample at this stage, a lot of benefits in food security. And I think we'll see how this plays out with our as we continue to survey and see how things if we do see a benefit here. But ultimately, I mean, the hypothesis is that if you do have reductions in energy insecurity and disconnects, and you have improvements in that affordability categories, that you start to see reductions in the types of trade-offs that Bruce and Emma both talked about in terms of having to make the difficult decision. But what we are seeing in the post weatherization treatment group in the time of COVID is that you do have fewer people having to go an entire day or night without food. And I imagine that's because of increased opportunity to food assistance and food banks, schools handing out more food to caregivers. So I think we'll also have to consider the increased opportunities for assistance during COVID-19 when we think about how to attribute these benefits or improvements that we see in our survey. So what is happening externally in the social environments locally and across the state. So Bruce, if you want to move forward, and this is our last slide. And okay, so I think that we just had 3 other considerations that couldn't really find necessarily in our KEEM or home uplift studies, but we think are important for thinking about energy, home energy, COVID-19, and other health issues. We have participated in an interview study with Knoxville area refugees, and we are finding that they are particularly vulnerable to energy affordability issues in Knoxville right now, either because of their loss of work or lack of informal support networks that are usually necessary for childcare needs, emergency childcare needs, and also, from contracting COVID-19. And then you also have refugees that are having really language barriers and trying to navigate systems that they're unfamiliar with, like accessing energy affordability or energy assistance. So that is a particularly vulnerable group. I think that's important to remember as we do our outreach activities and really think about the impacts of COVID-19. Respiratory health, we're finding that asthma prevalence and prevalence of COPD and other respiratory distress issues, diagnoses are higher in the weatherization eligible population than the general population, and even higher than the low income or people in poverty that aren't accessing this program. So it's a driving factor for some of these households in terms of they're applying for low income weatherization. They recognize that their homes are making them sick. So thinking about COVID-19 and these underlying issues and these racial disparities, social determinants of health, you have a population of people that is unwell and experiencing respiratory distress. And if we can improve the home environment through projects or in programs like weatherization or weatherization plus health programs, then you give them a better chance at being healthier in case they do contract COVID-19. And then that moves us into those who are medically vulnerable. We find in the multifamily study that 14% of the sample reported having medical equipment that would stop working without power. And about half of those reported that if that happened, that could result in a life-threatening situation. Similarly, 16% of the multifamily sample reported having prescription medications that required refrigeration. And same thing, about half of those reported that if that power went out, it could be a life-threatening situation. So again, thinking about the energy affordability issue, how can improved energy security, fewer disconnects for this medically vulnerable population give people their best chance against something like COVID-19? And that's it.
Fantastic. Thank you. Folks, feel free to put your questions in the Q&A box. I will ask one about the audience beyond the TVA for your work. do you all have, it's very powerful data that you've collected, and it's data and it's valuable. And I'm wondering, you know, you obviously have an obligation to share it with TVA and with the Robert Wood Johnson Foundation, but where can folks find out what you do with those 2 pre and post COVID samples? And yeah, you talk a little bit about what happens next.
Okay, well, we have a report that we're preparing for the Massachusetts Program Evaluators, which will have almost all of our multifamily results. And that report is almost in its final draft stage, and that'll be posted on the Energy Efficiency Council's webpage in Massachusetts. We do need to publish our stuff, so we're happy to give presentations and share our PowerPoints. We are working on some journal articles and reports, but you caught us.
I guess I asked the question less. I think it's impressive that the TVA recruited 75% people of color. I mean, it's proof that it's possible, even if the majority of your residents are people of color. And so I just think this is powerful data and proof that you can do this work and then take it to the next level. So I'm appreciative of you sharing it in such a clear way for those of us who don't do stats that often. If we have any other questions, I will assign them to you, and you're welcome to answer them at your leisure. Thank you very much to both of you, Dr. Tonn and Erin. And I am going to switch privileges to our friend in Fort Collins, who is representing Illinois, which a little confusing, Paul, but you can explain that. So I'm going to introduce Paul Francisco while he gets his presentation up. Paul is a senior research engineer and is the director of the Indoor Climate Research and Training, or ICRT group, at the Illinois Applied Research Institute at the University of Illinois at Urbana-Champaign. His research focuses on the intersection of energy efficiency and indoor air quality, and his projects are primarily conducted in field environments and include indoor air quality sampling, energy use logging, and airflow and insulation characterization of buildings. Paul has a Bachelor of Science in Mechanical Engineering from the University of Delaware and a Master's of Science in Mechanical Engineering from the University of Washington. We're very grateful to him for joining us, and without further ado, Paul, take it away.
Okay, thank you very much, and thank you very much for having me. I hope it's okay to have arrows and graphics in the title. It doesn't really lend itself to having the title written out very easily elsewhere, but so I'm going to talk this evening about ventilation and how it intersects with energy efficiency and infectious disease transmission. And so, oops, there we go. So a brief overview. I'll talk a little bit about air exchange in buildings and how it works, how ventilation factors into energy efficiency, which was discussed somewhat by Emma, and then also ventilation and infectious disease, which we didn't worry about that as much before. It's kind of become important right now. So there's a general importance of ventilation when we're in a time of focusing on infectious disease. Then I want to talk about a couple of special cases. One is the isolation zone, and one is the sheltered zone, and we'll talk later about what those are. So first, briefly about air exchange in buildings. There are three general mechanisms. One is called the stack effect, and that's basically from the temperature difference. You can think of it as also like a chimney effect. There's effects of airflow from wind, and then also mechanically induced ventilation. So with the stack effect, we have a situation where, say, warmer air, as cold air comes into the home, it warms up, warm air rises, and that then creates a suction that pulls air in from the bottom of the building. So we've got air coming in at the bottom in the wintertime, rising and going out at the top. So that is a major way that we get air exchange. That's primarily through leaks. It's not something that's driven by a fan. That is because we have holes in our houses. Then we also have the wind effect, where the wind is blowing on one side of the building, so that pushes air in and creates a suction on the opposite side of the building, which pulls air out. So the two of those together, the stack effect and the wind effect, become natural infiltration. And that is what we would get if we didn't have any mechanical ventilation. Now, in terms of mechanically induced ventilation, some of it will be from combustion appliances. If we are, say, burning natural gas to heat our water and it's taking air from the house as the air needed for combustion, and then it vents outside, that is acting kind of like an exhaust fan. We can have mechanically induced air exchange from duct leaks, because when ducts leak from forced air distribution systems, that may create imbalances that will pressurize or depressurize the house. And then we also have ventilation that's actually intentional. It can be exhaust, it can be supply, and it can be balanced. So that's just a brief overview of the mechanisms of air exchange that I think are important when we start thinking about ventilation overall. And let's see. So let's talk about ventilation and energy efficiency. This is a topic that has been somewhat controversial for the last bunch of years, especially in energy efficiency programs, where people are saying, hey, we want to save energy. How does ventilation save energy? Because you're taking that heated air and throwing it outside. Well, ventilation itself, of course, does not save energy if it's entirely just focused on the ventilation. However, if we're doing air sealing, we still need to maintain indoor air quality. And this is something that we're focusing on even more right now. New homes have gotten to be quite tight. What happens when you have a really tight home and people start getting sick? Or in retrofit homes, as we make them tighter, what happens? And so a question that people ask a lot is, why not just leave buildings leaky? Why do we spend money sealing all the holes and then we spend money putting in ventilation? Isn't that kind of nuts? Well, it's not kind of nuts. So here's the issue. I talked about the ventilation from stack effect and from wind. Well, those are just the wind is kind of random. Stack effect, you get more of it when it's cold, you get less of it when it's mild. So this is a graph that's using I'm assuming 4,000 cubic feet per minute at 50 Pascal house. We don't need to go into what exactly that means, but just think of it this way. That is the average starting leakage level. That's a metric of leakage. It's the average starting leakage level for homes in the Illinois weatherization program for low-income residents. So that's an average older house in our low-income populations. And so I've also put on here what the ASHRAE standard 62.2 target ventilation rate would be at 75 CFM, assuming a 1,500 square foot house with 3 bedrooms. So this, on the bottom, we've got outdoor temperature, and I'm assuming it's 68 degrees inside. And then on the y-axis, we have the ventilation rate when you include the stack effect only. We haven't even gotten to the wind yet. And so what we see is that for this average house, there's a whole lot of time where we are ventilated much more than we need to be. And when it's 0 degrees or 10 degrees Fahrenheit outside, it can be very expensive to heat that air. So basically, that all represents wasted energy. Well, so what we do is we do air sealing. Oh, and we also have underventilation even at the mild times if people don't open their windows. Many times people will open their windows when it's 60 degrees and higher, but there are many people who don't or feel like it's unsafe to. So what we do is we do air sealing. And so maybe we've cut that leakage in half. The house, we've sealed up half the leaks, and so now we have half the leakage. Well, if we just do that, then we've saved all this energy. That's great. That's why we're doing our air sealing, is to save all this energy. But we have much more under ventilation, and now it can be under ventilated even when we're down at, say, 40 degrees where people are not as likely to have their windows open. So what we'd really like to do is be able to pull the overventilation at the cold temperatures down and bring the ventilation at the milder temperatures up. And that's what the ventilation, air sealing, and then adding ventilation is all about. So what this shows here is if you had that house where you cut out half of the leakage, but then you put in a fan that was big enough to meet the target, you would have certainly sacrificed some of the energy savings, but you still get a lot of energy savings. So it becomes, because we can't just not worry about indoor air quality and not worry about health and just chase energy savings entirely, we need to consider the health side and maintain health and safety of the residents. That is why we do this combination. By reducing the air leakage, and we reduce drafts. So many of the things that were discussed by Emma and by Bruce and Erin in terms of social determinants of health and cold temperatures, things like that, we've really reduced that while still maintaining a reasonable level of indoor air quality. Now, one thing about it, reasonable level of indoor air quality is assuming kind of normal situations. It's not assuming we have something just totally crazy going on like a pandemic. Well, we do have something crazy going on like a pandemic. And so now we have to think about it a little differently. So I'm going to move into ventilation and infectious disease. So we're going to kind of leave the energy part behind. We've done a lot of air sealing of buildings. We've put in some ventilation. What role does ventilation have with infectious disease indoors? So let's start by assuming that airborne transmission is indeed of concern. And about a week and a half ago, the CDC posted something that said airborne transmission is real. A day later, they took it down and said, it was a draft. I think it was yesterday they put it back up and said, yes, airborne transmission is real. So let's go with that. Let's assume that airborne transmission is real, and I think there's plenty of evidence to show that. Let's also recognize that viruses are suspended in particles. They don't float around entirely by themselves. They get suspended in drops that can be of a whole range of sizes. Now, indoors, there are two considerations when it comes to infectious disease transmission. One is proximity. Proximity is how close two people are. So if somebody else is infected and you're really close to them, that's all about proximity. That's what the social distancing is about, the 6 feet away, is to try to keep proximity, try to keep people from being really in proximity to each other. Proximity is an issue indoors, it's an issue outdoors. But what we have indoors that we don't have outdoors is confinement. Outdoors, people breathe and it just disperses. There's a bit of a plume. We're worried about that 6 feet away, but then their exhalation tends to disperse. Indoors, it can't just do that because we have these things called walls and ceilings and floors. So when we are confining it, we end up having concentrations building up. And so we have this confinement issue indoors that we did not have outdoors. I'm going to show some graphs in a little bit that show how ventilation and infectious disease transmission can interact. But first, we need to think about particle sizes. So we're going to talk about 3 different particle sizes. One is 100 micron particles, or micrometers. Those are the big ones. Those are the big droplets that tend to fall quickly. Somebody sneezes, there's a big droplets, they fall out, and that's really what the 6-foot rule protects against. Ventilation is not going to do very much, if anything, about the 100 micron particles, because after 6 feet or so, they should mostly be on the floor or on the furnishings or whatever. They're not really floating around in the air for an extended period of time. Then we have the 10 micron particles. These can stay in the air for a while. They also will have substantial deposition. Deposition meaning whether it's to the floor or to the walls or other surfaces, they will get removed as they get to other surfaces, but it's not at the same level as the 100 micron particles. The 10 micron particles, the masks are really effective. And the fact that we're seeing that masks are so effective for people, and when people stop wearing masks when they're indoors, we tend to have these events. We see evidence that probably the 10 micron particles are important, but we haven't proven that. I'm going to also talk about even smaller particles, 1 micron particles. These are really tiny. You can't see these. these can remain in the air for a long time. There is still deposition, but not nearly to the level as for the 10 micron particles. Masks are not as effective on the 1 micron particles. So for the 1 micron particles, they're not falling out like the 100 micron ones do. They're not falling out some and having masks be effective like with the 10 micron particles. So the 1 micron particles can just stay in the air and float around for quite some time. Unfortunately, with this particular virus, we really don't know what sizes are important. I mean, we're pretty sure that the 100 micron particles are important if you have not avoided proximity. And if you haven't avoided proximity, you don't get to worry yet about what's floating around in the air because you're catching it right away before you have to worry about buildup in the air. There is evidence that the 10 micron particles may be important just because of the effectiveness of masks, and 1 micron particles, it seems quite likely that they will also be important because they can remain in the air for such a long time. So I want to introduce a concept called effective rebreathed volume. We have a paper in review right now on this. This paper is available as on an archive server as a preprint. And it is a way to try to think about if somebody elsewhere in the room is breathing, what are you breathing in terms of the particles that they breathed out? And it's the particles that matter here for infectious disease because it's the particles in which the virus is suspended. So the idea is people breathe out of everything that they breathe out. What fraction do you breathe back in? But we make an adjustment. The adjustment is to account for the fact that some particles have fallen out or been removed by some type of process. We also assume a well-mixed room so that once you get past that immediate plume out of somebody's mouth, the room is pretty well mixed in terms of everything else. So for 100 micron particles, because those are going to fall out pretty quickly, if you're 20 feet away, your effective rebreathed volume, or ERBV, for the 100 micron particles will be near zero because there really aren't any left by the time it would get to you 20 feet away. Let's say that somebody breathed out and half of the particles fell out before you rebreathed their air. Then let's say you had breathed in a liter of their air. The effective rebreathed volume would be only half of that because half of the particles had fallen out. So it would be like you had breathed in a half a liter of their air. And for the 1 in 10 micron particles, they can linger until they're removed by ventilation or deposition. Okay, so I hopefully will be submitting this paper soon. This is not the paper I just said has been submitted. This is one that, it's one of those any days now, and any day now has not yet happened, but hopefully will happen shortly. So what I did here was I took this concept of effective rebreathed volume and looked at 1 in 10 micron particles. I didn't look at the hundreds because they fell out. So I looked at the 1 in 10 micron particles and I looked at the effect of air exchange rate and I looked at the effect of building height. So I'm assuming 1,000 square feet space. And then I looked at the ASHRAE standards for residential and non-residential buildings, and what would they require for the non-residential, what would they require in terms of air exchange rate? And that's going to be based on per person and per square foot of floor area. For residential buildings, I just looked at, we've got thousands and thousands of measurements about the leakage rates in residential buildings. So residential buildings are mostly going to have between 0 and 1 air change per hour under normal conditions. And then I've got on here offices and grocery stores are going to be around half an air change. Schools, if it's a 2-story height of a room, if you got, say, 16-foot rooms, it'll be about 1 3/4 air changes. If you have 8-foot ceilings, then it's going to be about 3.5 air changes. Bars are way up at around 4.5 air changes. I assume 16-foot ceilings for bars. The bars typically have higher ceilings. What we see here is for the 1 micron particles, you can have a really strong effect of ventilation. If you have very little ventilation, like you see in some really tight homes, you can have out to about 0.5 liters of effective rebreathed volume of the 1 micron particles. And about 60% of that is removed if you have 5 air changes. So 50-fold increase in ventilation, which corresponds to 60% reduction in how much you breathe in. It's also interesting, this was focused specifically at 1 hour. And the reason we chose 1 hour is because that is a common amount of time for people to be in a class, for people to be in a restaurant, for people to potentially be in a grocery store. And this is basically, you can think of it as you walk into this space at the same time as somebody who is infected. One of the things I thought was interesting is at 1 hour, if you're talking about the 1 micron particles, having that extra 8 feet of height gives you about the same benefit as 2.5 air changes of ventilation. That reduces over time because the space starts to get saturated with the particles and eventually it gets to be much less effective. So if we look at over 8 hours, remember, we just looked at 1 hour, so that's down here 60 minutes. So this is the 1 micron particles. We see at 60 minutes, it's not very much. And I failed to say, on the previous slide and on these slides, there's this dashed line. The dashed line is what you get if you are 6 feet downwind of a person outdoors. So that is for 15 minutes. So that is when people talk about being 6 feet away from somebody outdoors, that's about the number that you would get. So what we see is that indoors, you pretty quickly get over that amount. And when you don't have much ventilation at all, so very tight home, for 1 micron particles, over 8 hours, which is a time you might be in an office space, you might get 18 liters or so of effective rebreathed volume. If you have 1 air change, that goes down to about 6. Having the extra story of height is worth about half an air change out at 8 hours. For the 10 micron particles, it's much less, only up to about 1.5 liters instead of 18 for the really, really tight space. And you also see these are pretty straight. That's because deposition is also removing particles. What we see is that ventilation can have a really big impact. You know, if that 50-fold increase in ventilation corresponds to a reduction of about 2/3. So ventilation can really reduce how much you get from these particles. I know I'm running short on time, so I'll go through isolation shelter zones pretty quickly here. Isolation zone is when you really need to keep, both of these, when you need to keep people apart. Isolation is like somebody is sick or needs to quarantine, but they're going to be in the same house as you. You want to keep them away from you and not have their air mixed with yours. Sheltered is more like somebody might be particularly sensitive and they need to shelter when somebody is coming in from outdoors, maybe a caretaker that could have been exposed. This could also be used in non-pandemic situations. Isolation zone, the idea is define a space. In this case, it's defined by a darker border. Ideally, it has a bathroom. It's at least a room that somebody can be in. Have say a box fan in the window. Exhaust from that space. You have to seal off any supply registers and return grills and other major leakage sites between the house and those rooms. But the idea is you want to depressurize that space, not have the air that the room that the person is in mixed with the rest of the house. So you depressurize that room, keep fans in the rest of the house off, and just let them be in that room while that fan is running. And that should keep their air from mixing back to the rest of the house. Sheltered zone is basically the reverse. You want to push air away from the room that the person is sheltering in. You can exhaust from the rest of the house, and that should help protect that person from others coming in. This slide has some resources that we have online. It's in Spanish and in English. So summary, ventilation plays a key role in energy efficiency, can be important in disease transmission, most important for space with low existing ventilation rates and long occupancy. Higher ceilings can be beneficial as well, and ventilation can be used to isolate or shelter. Questions?
Wow. Lots of things out there.
Yeah, so that is not quite hot off the presses, some of that stuff.
Well, thank you so much for sharing. We have a question from our friend Mark Kravitz, who's asking if you can talk about the pros and cons of air exchangers, and also if there's an appropriate time or place to use them?
Okay, so are we talking about like air-to-air heat exchangers or ERVs, HRVs? I believe is what he's talking about. And if that's what we're talking about, HRVs and ERVs, they are, in my view, especially valuable in tight buildings, in tight homes especially. When you have a leaky building, the HRV or ERV doesn't make a lot of difference relative to just having exhaust or supply ventilation. But when you have really tight buildings, the exhaust only or supply only can create pressure differences that are not very good. You probably have a fairly energy efficient building at that point. You'd like to recover that heat. And so that balanced ventilation that you get from those can be really, really valuable. It's of course important to maintain them. If you don't maintain an HRV or an ERV and you let the intake clog, you end up having a really expensive exhaust fan. But as long as it gets maintained, tight homes, tight buildings, great application. Don't worry about it so much as an early step in leaky homes.
Great. Paul, if I could ask you to just talk for a minute about the training you do and the folks that you train through your center at the University of Illinois, and if there are any resources that folks can take advantage of online that mirror some of the trainings you give, or if there are online trainings. Can you just talk a little bit about the work you do in that space?
Sure. So we have what's called an IREC accredited weatherization training center. There are 18 to 24 of those around the country. So we are accredited to train people who are going into the weatherization workforce for energy auditor and quality control inspector. Everybody who comes in through the state of Illinois' weatherization program is required to come to our training. We also do what's called Healthy Home Evaluator training. Healthy Home Evaluator is a credential that is supported by the Building Performance Institute, and it's intending to take people who are already energy auditors, quality control inspectors, have that kind of background building science knowledge, and train them to look at homes from a health perspective as well. And in terms of online, next week, we are going to be piloting our online Healthy Home Evaluator course. We've got funding from E for the Future for that, and we are going to pilot it with a small group of folks. And then, assuming that goes well, we'll make a few edits because nothing's perfect the first time. And then I hope that we'll be able to offer that around monthly. That's going to be our primary online training for the near future. But we will see what we end up doing, going forward.
Awesome. If anyone has any other questions for Paul, you can put them in the chat, or for any of our speakers. We have just about 10 minutes left, and I am going to turn it over to my colleague and friend, Rachel Shawley. Hold on one sec. Who's going to tell us a little bit about the EERMC, which is the sponsor of this event today. I'm just going to bring up my screen. It's me.
And can you hear me okay?
Yes.
All right.
So glad we can be together for me to make sure my email is secure. Okay. So
I can get started a while.
Sure, take it away.
So my name is Rachel Shawley, as Kate said, and I am a consultant to the Rhode Island Energy Efficiency and Resource Management Council, which is sponsoring this year's lecture series. I think Kate mentioned that in the beginning. So the council is really excited to be supporting this series of important conversation around the impacts of COVID-19 and energy efficiency. And as we've heard tonight, this involves much broader conversations around equity, justice, health, workforce, and the economy. So for those who aren't familiar, the EERMC, Energy Efficiency and Resource Management Council, was established in 2006 to oversee the procurement of energy efficiency in Rhode Island. So basically, all of our efficiency programs, and to make sure that all Rhode Island energy consumers get the maximum benefits from those programs. So the council has 15 governor-appointed members representing small and large business, homeowners and renters, nonprofits, municipalities, the environment, codes, etc. And we have meetings every month that are open to the public. And so our ask now is for you, anyone who's in Rhode Island, and I guess since our meetings are virtual now, they are open to anyone who can tune in, but we encourage you to attend and to participate in the efficiency planning process for the state, because it is an open process, and we encourage that, that engagement with the public. So actually, our October meeting is tomorrow afternoon, and National Grid's going to be presenting its 2021 energy efficiency plan. So it's the perfect time to weigh in or just join and see what it's all about. So you can also learn more on our website at rieermc.gov or .ri.gov. And I think that's about it. So on behalf of the council, thank you so much for joining us tonight. Thank you so much for the speakers who have joined us from all over the country. And I'll pass it back to Kate to wrap it up.
Great, thanks, Rachel. So if you're in Rhode Island, get involved. And if you'd like to learn more, we happen to have 2 more fantastic lectures planned for 3 weeks from tonight. We have a great slate of speakers, and they're going to be talking about energy efficiency in schools, safer buildings, healthier students. I think the COVID-19 and building health situation is layered onto all of these topics. And so if you're interested in learning more about that, that is a free lecture as well, Wednesday, October 28th at 6:30. And then the final lecture for this year is scheduled for 6 weeks from today, which is Wednesday, November 18th. And we're really going to focus in on barriers to energy efficiency and rental and affordable housing, but also talk about some example solutions that can be scaled up or down. And so lots of important conversations. I want to thank Emma, Dr. Tonn, Erin, and Paul for being here. It was fantastic. If folks have questions for our speakers, you're welcome to enter them in the chat and we'll send them along. I am going to check the Q&A one more time just to make sure we don't have any more questions. And I think we are good. So again, you'll receive an email with a survey link. We thank you many times over in advance for completing that. And thank you again to all of our speakers and to the EERMC for sponsoring this important conversation. We hope to see you all again in 3 weeks. Have a great night.
Thank you.
Thank you.
Thank you.
Bye, everyone.